Bismillahirrahmanirrahim. Today my topic is malaria. Education is the passport to the future, for tomorrow belongs to those who prepare it for it today. Outline of today's presentation is introduction, epidemiological determinants, chain of transmission and communicability of malaria, clinical manifestation of malaria, levels of prevention and recent advances related to malaria. Learning outcomes. By the end of this presentation, participants will be able to understand the epidemiological determinants of malaria, clinical features of malaria, national and global malaria prevention strategies and updates. What is malaria? Malaria is a mosquito-borne febrile disease caused by the malarial parasite. Malaria means mala means bad and area means air. It is actually a protozoal infection, a disease caused by member of the protozoan genus Plasmodium, which mainly affect the human liver and red blood cells. Humans are infected with Plasmodium parasite when bitten by infected female Anopheles mosquito vector. Symptoms may appear within the week to months or even years. There are four species of malarial parasite: Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, or Plasmodium malariae. Here, problem statement. Uh, if we see the global burden of disease in 2019, there were estimated to 29 million cases of malaria worldwide, and estimated number of malaria deaths is 409,000 in 2019. Children aged under 5 years are the most vulnerable group affected by malaria, and they account for 67% of all malaria deaths worldwide. Malaria affects many regions. It affects the Middle East, America, Latin America also, but the most disproportionate high share of global malaria burden is the African region. In 2019, the region, this WHO African region was home to be 94% of malaria cases, death and cases and death. If we see the vulnerable group or specific risk group for malaria, young children in stable transmission areas are at high risk, non-immune pregnant women, semi-immune pregnant women in areas of high transmission, semi-immune HIV-infected pregnant women in stable transmission areas, people living with HIV and AIDS, international travelers for non-endemic areas because they lack immunity, immigrants and their children living in non-endemic areas and returning to their home countries are the specific risk groups for the malaria. If we see the situation of malaria in Pakistan, as the figure shows, there is in 2018 there is 374,513 cases, confirmed cases of malaria. From these, the most common is P. vivax, Plasmodium vivax, 575 cases, and P. falciparum is 55 and 639 cases. And you can conclude that the most of the infection is caused by Plasmodium vivax. If we see the annual parasite index, which is used to estimate the eradication of the malaria, and I discussed later on, in 2019, the most high index of is seen in total district is total is 12.9, and is highest is seen in Balochistan, which is 4.1, then Khyber Pakhtunkhwa 3.7, and Sindh 2.6. And the high annual malarial parasite index was seen in the Balochistan. Now come towards the epidemiological determinants, agent, host and environment. As we discussed, agent, there are four species of malarial parasite: Plasmodium falciparum, vivax, ovale, malariae, and these four species are responsible for the malaria. Reservoir infection: a human as a person who harbors a sexual formed gametocyte. A patient can be carrier of several Plasmodium species at the same time. Children are more likely to be carriers than adults, and there is roughly estimate that at least 12 gametocytes per cubic millimeter of blood should be considered for carrier state. Period of communicability: malaria is communicable as long as mature viable gametocytes exist in the circulating blood in sufficient density to infect the vector mosquito. Gametocytes are the most numerous during the early stages of infection when their density may exceed 1000 per cubic millimeter of blood. They also tend to occur in waves in the peripheral blood. Malarial infection may be lapses, and the most common B. vivax and malaria tend to relapse more than 3 years after the patient's first attack. Recurrence of falciparum usually disappear within 1 to 2 years. Plasmodium malaria has tendency to cause prolonged low-level asymptomatic parasitemia in the blood. If we see the life cycle of the malaria parasite undergoes two cycles of development. One is the human cycle, which is also known as asexual cycle or exogenous cycle, and it is also called schizogeny. And the another cycle is the mosquito cycle, which is known as sexual cycle or sporogeny cycle. In this, man is the intermediate host, and mosquito is the definitive host. The asexual cycle, endogenous phase in the human, is further divided into the hepatic phase, erythrocytic phase, and gametogenic phase. Duration of erythrocytic phase is constant for each species. In Falciparum vivax and ovale it is 48 hours, but in malaria it is 72 hours. If we see the cycle of the malaria, first of all, the mosquito bite the human and from the blood meal and inject the sporozoid in the blood. The sporozoid remain in the blood for limited period of time, 60 minutes, and majority of the sporozoid is destroyed by phagocytes. Some gain entry into the liver cells. In the liver and in the liver, they infect the liver cells and passes through the exoerythrocytic phase, and in the liver cell they infect in the liver they infect the liver cells and undergo the developmental stage, which is known as schizont stage. After 2 weeks, schizont become mature and they rupture and release the merozoids then, which is released from the ruptured schizont, is then infect the red blood cell, which is now the exoerythrocytic phase is over and the red blood cell erythrocytic phase start. In the red blood cell, they passes through further stages, and receptor present in the on the membrane of the red blood cell, they attach with the receptor and gain entry into the red blood cell and undergo a stage which is known a ring stage, which is known as immature trophozoid stage, and then further trophozoid stage is undergo the schizont stage. Schizont stage then ruptured and release the merozoid, and which they further infect the red blood cell, and this cycle repeat until the which can infect the fresh red blood cells, and the cycle is repeated over and over again until it is slowed down by the immune response of the host. Some immature trophozoids undergo another cycle which is known as gametogenic cycle. In all of the species, some species of gameto which do not divide but become male and female gametocyte, and they are the sexual form of the parasite which are infective to the mosquito. Now come the sexual cycle, which is exogenous phase in the mosquito at its sporogynous phase. In the sexual cycle, the two sporozoid, mature trophozoid, which is undergo into change into the gametocyte, is divided into the male and female in the mosquito. When the mosquito takes the blood and then it enters into the mosquito stomach and further mature into the microgametocyte and macrogametocyte. Macrogametocyte is actually the female gametocyte and the microgametocyte is actually the male gametocyte, and it undergoes a process which is known as exflagellation. 4 to 8 thread-like filaments called microgametes are developed, and the female gametocyte undergo a process of maturation which is known as macrogamete. Through the process of chemotaxis, microgametes are attracted towards the female gametes, and one of which causes fertilization of the female gamete, and the resulting zygote is at first motionless body within the 18 to 24 hours in the mosquito, which is known as ookinete. Becomes motile. This is known as ookinete. Ookinete then enter into the mosquito stomach and attach the outer layer of the mosquito stomach and become the oocyst. Oocyst further go under the development and passes through the stages, and then ruptured oocyst further release the sporozoid in the mosquito, and from many of gain entry into the mosquito salivary gland, and when the this infected mosquito bite the humans, then they further inject the sporozoid and the cycle repeats. When we talk about the host factor, age, malaria affects all ages. Newborn infants have considerable resistant to infection due to high concentration of fetal hemoglobin during the first month of life. Gender में males are more frequently exposed than females due to their outdoor activities. Females are better clothed than males. Race में individuals with the sickle cell anemia have milder infection. Pregnancy में pregnancy increases the risk of malaria in human. Malaria during pregnancy may cause intrauterine death in fetus, and it may also increase the premature labor or abortion. Socioeconomic development. Malaria is directly related with the socioeconomic development. It is observed that the malaria has disappeared from most of the developed countries due to the socioeconomic development. Houses. It is most common in ill ventilated and ill lighted houses, and it is ideal for resting of mosquito for breeding. Population mobility also affect laborers connecting with engineering, irrigation, agriculture, and other projects. Migrating are more disposed to the developed malaria. Occupation में malaria is predominantly a rural disease and has direct connection with agriculture and related occupation. Human habits, the people which are sleeping outdoors, nomadism, and absence of the personal protection are the risk factor of contracting malaria. Immunity epidemic. Malaria is influenced by the immune status of the population. Immunity is acquired after several repeated exposure over several years in the malaria. If we see the environmental factors, temperature, malaria is actually the seasonal disease, and the greatest prevalence of malaria from the July to November. Temperature is optimal temperature 20 to 30 degrees centigrade for the 20 to 30 degrees centigrade is favorable for the development of the mosquito. If the temperature is below 16 degrees centigrade, then their parasite cease to undergo development in the mosquito. Temperature 30 degrees centigrade lethal for the mosquito. Humidity, relative humidity 60 degrees, 60% is also favorable for the development of mosquito. Rainfall further increases the atmospheric humidity, but the rainfall has also paradoxical effect in the some areas, as it several epidemic of as the lesser monsoon leads the formation of small pools of water in river, which act as a breeding places for malarial vectors. The relationship between rainfall and mosquito breeding is fundamental importance. Altitude when not found above 2,250 meter is ideal for the is not found malarial anopheles mosquito not found at altitude above 2000 to 500 meters due to the unfavorable climatic condition. Man-made malaria, garden pools, irrigation channels, engineering projects like construction of hydroelectric dams, roads, bridges had lead to the breeding of mosquito increase in the malaria. These malaria which due to this is known as man-made malaria. Now we discuss the vector of malaria in Pakistan. There are 45 species of Anopheline mosquito. Overall, the two species, A. colcifacius, which is mainly responsible in rural areas, and A. stem fancy in urban areas, are known primary vectors involved in the transmission of malaria. Both the vectors are considered to be essentially endophilic in the directional resting and mainly zoophilic. The main factors which determine the vectorial importance of mosquito is the density. To be an effective vector, a species must be present in adequate density, and there is a critical density below which the effective transmission cannot be maintained in the community. This level varies with different species, and lifespan is another key factor in the transmission of malaria in the lifespan of the vector. The vector mosquito live at least 10 to 12 days after the infective period blood meal to become infective. This strategy in malaria eradication is shorten the lifespan of mosquito is less than 10 days, but insecticide is actually in the use in the malarial eradication strategies. Choice of the host. Some mosquito prefer human blood, some animal blood, and some changes. After blood meal, some bacteria rest indoors on the walls for quite some time. This behavior habit of mosquito known as endophily, and which species and other species which rest outdoors is called exophily. It is a basis for organizing rational anti-drug measures. In fact, the concept of malarial eradication is based on endophilism, indoor resting habit of most malarial vectors. The breeding habits of mosquito vary considerably. Some breed in moving water, some in brackish water, and some in the fountains and cisterns. Time of biting. Time of biting it can vary. So the most Anopheles mosquito bite at the night, except the Aedes aegypti mosquito, which is during the sunset or sunrise. Anopheles mosquito have nocturnal feeding habits between dawn and dusk. If we see the mode of transmission, malaria is most commonly caused by the biting of the mosquito. Other transmission is from the mother to child through blood transfusion by sharing needle used to inject drugs, but it is very rare mode of transmission. If we see the incubation period, it can also vary between the species of parasite. Falciparum malaria's incubation period is 12, average 9 to 14 days. Vivax malaria is 14, 18, 8 to 17 days. Oval malaria 17 days. Quartan malaria 28 days. And longest, greatest incubation period is seen in the quartan malaria, which is 28 days. Now we come to the clinical features of malaria. If we see the clinical features of malaria, it presents with high grade fever with headache, restless, anorexia, diarrhea, arthalgia, vomiting, anemia, chills with rigor, hepatosplenomegaly, convulsions, and coma. Typically, paroxysmal attack of malaria for fever found in three stages: cold stage, hot stage, and sweating stage. Cold stage, the onset is with lassitude, headache, nausea, and chilly sensation, followed by in hour. The temperature rises rapidly to 39 to 41 degrees centigrade. Headache is in the cold stage is often severe and commonly there is vomiting. In early part of the stage, the skin feels cold, later it becomes hot. Parasites are usually demonstrable in the blood. The pulse is rapid and may be weak. This stage lasts for 1 hour. Now comes the hot stage. Patient feel burning hot and cast off his clothes. The skin is hot and dry to touch. Headache is intense but nausea commonly diminished. The pulse is full and respiration rapid. This stage lasts for 2 to 6 hours. Now, a third stage, sweating stage. In this stage, fever comes down and profuse sweating. The temperature drops rapidly to normal and skin is cool and moist. The pulse becomes lower. Patient feels relieved and often feels asleep. This stage lasts for 2 to 4 hours. The febrile paroxysm occurs with indefinite intermittent periodicity, repeating every third or fourth day depending upon the species of malarial parasite. The classical three stages, cold, hot, and sweating, may not always be observed due to maturation of generation or parasite at different times. Period of latency may last several weeks or months. The disease has tendency to relapse and is characterized by enlargement of spleen and secondary anemia. In patients with Plasmodium falciparum, the infection with primary fever is its few days is usually irregular, even continuous, and then classical 48-hour periodicity becomes established, and the fever may become continue to irregular. And the hot and cold stages of typical other malaria infection, less clearly separated from one another in Plasmodium falciparum. If we see the Vivax infection, its symptoms are similar with the Plasmodium falciparum and further divided into hot and cold stage. Vivax also little different. Whale is also little different from Vivax. However, they tend to milder infection than Vivax and cease after a few parasitism. Clinically, the Plasmodium malariae attacks resemble to those of Vivax, but the cycle is 72 hours instead of 48 hours. If we see the complication of falciparum, uh, fever, black water fever, ARDS, low blood sugar, cerebral malaria, infections, pulmonary edema, anemia, renal failure, urine output decrease, and metabolic acidosis are the complications of the Plasmodium falciparum. Diagnosis of malaria. It is basically guided into the microscopic diagnosis, blood smear, fluorescent microscopic, quantitative report, antigen detection, immunochromatography, dipstick is rapid diagnostic test, which is based on the detection of circulating parasite antigen with simple dipstick format. Serology, ELISA, molecular diagnosis, PCR, real-time PCR. In the microscopic examination, there are two types of film, thick film and thin film. The thick film is used in searching for parasite, and in the thin film, it is used for identification of the species of the malaria. Thin film blood is used to confirm the Plasmodium species present. The advantage of microscopy are the sensitivity is high and it is possible to detect malaria parasite at very low density. It also helps to quantify the parasite load and possible to distinguish the various species of malarial parasite and their different stages. Measurement of malaria. The measurement is divided into three era: pre-eradication era, eradication era, and vector indexes. In pre-eradication era, the magnitude of malaria was determined on the basis of diagnosed cases. The classical malaria measures in the pre-eradication rise spleen rate, average enlarged spleen parasite rate. Spleen rate is a percentage of children between 2 to 10 years of age showing the enlargement of spleen. And in the spleen rate, the adults are excluded from the spleen stage because causes other than malaria frequently played in causing splenic enlargement in them. Average enlarged spleen, this is further refinement of spleen rate which denoting the average size of enlarged spleen. And then the parasite rate is defined as a percentage of children between ages 2 to 10 years showing the malaria parasite in their blood. There is also parasite density index, infant parasite rate, proportional case fatality rate. If we talk about the eradication era, the microscopic diagnosis of the malaria cases became the main method of diagnosis. The parameters used for the measurement of malaria were mostly parasitological in nature. The commonly used parameters in the eradication era is annual parasite incidence, annual blood examination rate, annual falciparum incidence, slight positivity rate, and slight falciparum rate. In the annual parasite incidence, it is formalized confirmed cases during 1 year divided by population under surveillance multiply 1000. It is a sophisticated measure of malaria incidence in community. It is used for intense active and passive surveillance and cases are confirmed by blood examination. Areas with annual parasite index more than 2 per 1000 population per year is considered as high risk and therefore eligible for vector control. Vector index is a malaria survey is not complete unless it includes investigation related to the insect vector. Some of the important vector indexes are human blood index, porozoid rate, mosquito density rate, man biting rate, and inoculation rate. Now, the malaria control in Pakistan. Malaria control activities are ground since the formulation of Health Services Provision Fundamental in Boards Committee. In Pakistan, they are functional since 1950 through the succession of different approaches. Two major failures in the endemic countries control program in 1998 rollback malaria initiative was coordinated and started by WHO, UNICEF, and UNDP and World Bank. Pakistan, being to signatory to the pact, started rollback malaria implementation in phased manner by earmarking 273 million from the PSDP allocation of 5 years and for next approval for next 5 year 2007 2012 to support provisional programs. Under 18 amendment in the Constitution of Federal Ministry of Health along with its attached department, Directorate Malaria Control were devolved on the 30 June 2011. Malaria control strategic plan, if we see in 2015 to 2020 at glance, goal is for 2020 is reduce the malarial burden by 75% in high and moderate endemic district agencies and eliminate malaria in low endemic. Objective is to achieve less than 5 annual parasite index in high endemic areas of province Balochistan, Sindh, KP and Fata region by 2020 to achieve less than 1% annual parasite index within moderate endemic areas of Balochistan to achieve zero annual parasite index within low endemic areas of Sindh, KPK and Punjab. If we see the impact, it brings down the annual incidence rate of malaria to less than 5 cases per 1000 population in the 66 district agencies by 2020, bring down the annual incidence of malaria to less than 1 case per 1000 population in 10 districts by 2020, and at least 50% reduction in mortality due to mortality the year 2020, taking 2013 as a baseline. Prevention and control. Primary prevention, secondary prevention, and tertiary prevention. In primary prevention, health education and environmental modification, active intervention measures में आ जाता है कि first of all we can in active intervention measures we can stratify the problem essential features for planning and development of sound control strategy to maximize the utilization of available resources provide the guideline strategy and it must be suited. There is action for active intervention measures for individual and family protection for community protection. Reduction of human mosquito contact in individual and family protection, insecticide treated nets, repellents, protecting clothing, screening of houses. For community protection, insecticide treated nets and zoo prophylaxis. डिस्ट्रक्शन ऑफ एडल्ट मॉस्किटो में हम कम्युनिटी प्रोटेक्शन हम करेंगे, इंसेक्टिसाइड ट्रीटेड नेट्स, इंडोर रेजिडुअल स्प्रेइंग एंड स्पेस स्प्रेइंग। डिस्ट्रक्शन ऑफ मॉस्किटो लार्वा में इंडिविजुअल लेवल पे एंड फैमिली प्रोटेक्शन में पेरी डोमेस्टिक सैनिटेशन, कम्युनिटी प्रोटेक्शन में लार्विसाइडिंग ऑफ वाटर, इंटरमीडिएट इरीगेशन, सोर्स रिडक्शन में स्मॉल स्केल ड्रेनेज करेंगे, इंडिविजुअल एंड फैमिली प्रोटेक्शन फॉर कम्युनिटी लेवल, environmental sanitation, water management and drainage. Social participation में for individual and family protection, motivation for personal and family protection. For community protection, health for education and community participation. एक्टिव इंटरवेंशन में वेक्टर कंट्रोल स्ट्रेटजीज, एंटी डल मेजर्स में रेजिडेंट स्प्रेइंग करेंगे, स्पेस एप्लीकेशन, इंडिविजुअल प्रोटेक्शन मैन वेक्टर कंटेक्ट कैन बी रिड्यूस बाय यूजिंग नेट, एंटी लार्वल मेजर्स में लार्विसाइड यूज़ करेंगे, source reduction a technique to reduce mosquito breeding, site drainage of filling, deepening of flushes, management of water level, changing the salt content of water, intermittent irrigation, integrated control in order to reduce too much dependence residual insecticide, increasing emphasis being put on integrated vector control methodology which includes bio-environmental and then come the primary prevention, immunization, and chemoprophylaxis role. Specific protection. Malarial vaccination is a vaccine that is used to prevent malaria. The only approved vaccine as of 2015 is RTSRS, known by the name Mosquirix. It requires 4 injections and has a relatively low efficacy. Due to this low efficacy, WHO does not recommend the routine use of RTS vaccine in babies between the 6 to 12 weeks of 16 to 12 weeks of age. In chemoprophylaxis, it is recommended for the travelers from non-endemic areas and it is a short-term measures for soldiers, police and labor forces serving in highly endemic areas. Recommendation for short-term chemoprophylaxis less than 6 weeks include the doxycycline for children more than 8 years of age and which is started 2 days before travel and continued for 4 weeks after leaving the malaria area. If the chemoprophylaxis for more than 6 weeks, it is include mefloquine 2 weeks before, during, and 4 weeks after the exposure. It is contraindicated in people with history of convulsions, neurolepsy problems, and the cardiac conditions. The chemoprophylaxis malaria in Pakistan control malaria control program recommendation is same. The risk of contracting malaria prevailing species where Plasmodium falciparum and vivax both occur and type of species. The recommended prevention method may be mosquito bite prevention only or mosquito bite prevention in combination with chemoprophylaxis and standby emergency treatment. It is chemoprophylaxis is also divided according to the malarial risk. If the type A, which is related to very limited risk of malaria transmission, we can only provide the mosquito bite prevention strategy. If type B, which include risk of non-falciparum malaria, mosquito bite prevention plus chloroquine and doxycycline given. Type C में risk of falciparum malaria, mosquito bite prevention plus atovaquone, proguanil or doxycycline or mefloquine chemoprophylaxis is recommended. Now we come to secondary prevention is early diagnosis and treatment. If we see the treatment of malaria in Pakistan, the treatment of uncomplicated malaria in adults may include pregnant women may Vivix malaria when slide is positive clinical level give the chloroquine plus primaquine 1 tablet a day for 14 days. In falciparum malaria we give the sulfadoxine paramethamine or artesunate. Artemisinin derivative and partner medicine of should not be given as monotherapy then should not be available as monotherapy. Antimalarial should be taken with water. Ideally, the first dose should be given in the front of healthcare provider. Treatment of severe malaria if management at peripheral level facilities and private clinics. In unconscious patients, save the air. Here we take a slide, give first dose of injection artemether at single loading dose and artesunate suppositories and refer to the hospital along with slides and evidence of injection. Treatment in hospital. It is ABC approach. First of all, we can airway should be secured, unconscious breathing and circulation should be assessed, patient weight should be assessed, IV cannula should be inserted, and immature measures of blood hematocrit HP level. A detailed clinical examination should be conducted. Glasgow coma scale. Unconscious patient should have a lumbar puncture for CSF analysis to exclude bacterial meningitis. The degree of acidosis is an important determinant of outcome. If facilities are available, arterial capillary blood pH and gases should be measured in patients who are unconscious hyperventilation. Blood should also be taken for cross match. The assessment of fluid balance is critical in severe malaria. Respiratory distress, in particular with acidotic breathing in severely anemic children, often indicate hypovolemia and require prompt rehydration and when where infected blood transfusion. Specific treatment, antimalarial treatment, it is essential that antimalarial treatment in full doses is given as soon as possible in severe malaria. Two classes of drugs are currently available for parental treatment: Syncona alkaloids, which include quinine and quinidine, and artemisinin in derivative, which include artesunate, artemether, and artemotil. Quinidine commonly causes hypotension and concentration-dependent QT prolongation. Quinidine is thus considered more toxic and quinine and should only be used if none of other effective parental drugs are available. Electrocardiographic monitoring and frequent assessment of vital signs are required if quinidine is used. Treatment of severe malaria में recommended treatment जो है वो artesunate है, which is soluble in water and can be either by IV or IM injection. Quinine must never be given by bolus IV or as lethal hypotension may result. It is always be given as constant infusion. Quinine dihydrochloride should be given by rate control infusion in a saline or dextrose line. The maintenance dose of 10 mg salt per kilogram between should be repeated every 8 hours. If there is no clinical improvement or patient remains in acute renal failure, the dose should be reduced by one third after 48 hours. Dosage adjustment are not necessary if patient is receiving either hemodialysis or hemofiltration. Dosage adjustment by one third is necessary in patient with hepatic dysfunction. Following initial parental treatment, once a patient can tolerate oral therapy, it is essential to continue and complete the treatment with effective oral treatment. Currently, practice is to continue the same medicine orally are given parenteral quinine to complete a full 7 days of treatment. In non-pregnant adults, females, toxycycline is added to quinine and should also be given for 7 days. Adjuvant therapy with corticosteroid is not recommended. No significant difference in mortality between dexamethasone and placebo has been found on systematic reviews. But GIT bleeding is
Dr. Hansa, please, 1 minute, please. You have done a lot of hard work. I really appreciate it. If you please come to your conclusion slide and MCQ slide, and we can continue with the rest of your presentation in second session. Please come to your conclusions as well as your MCQs, please.
Madam, conclusion is that we cannot achieve malaria eradication without strong leadership and political will to make sustained investment and not only in malarial control but also in development environmental strategies. Black MCQ session, black water fever is a special manifestation of malaria. After sporozoite enters the human body, it undergoes developmental cycle first in liver, then in heart disease. Only after which fever is seen. This incubation period varies between plasmodium species and species has longest incubation period. Vary. A disproportionately high share of global malaria burden is seen in African region. Malaria tends to relapse more than 3 years after
C.
As are known as primary factors involved in transmission of malaria classes, and site falsifications, malaria is caused by type of microscopic parasite that are transmitted most commonly by fever to Field that smear film for malaria parasite used to determine malaria parasite present to confirm the plasmodium species malaria Areas with API more than 2 per 1,000 population per year have been classified as high risk areas, low risk areas, and intermediate areas. The treatment of uncomplicated sensible malaria in adults excluding pregnant The targets for global technical strategies for malaria 2016-2020.
Okay, thank you. Thank you, Dr. Hansa. It is a very extensive presentation. I must say that a lot of hard work has been put in. And there are many questions that has related with malaria prevention, especially that comes to my mind. Actually, what has been done is in 26 minutes you have presented aspects of malaria, and for prevention you have just 4 minutes, because at after 30 minutes I request you to please conclude it and start with your next MCQ session. So there are many questions regarding prevention that comes to our mind. First is about the disease prevention, how WHO could not achieve eradication